Neuroanesthesia management of cerebral autoregulation and intracranial pressure. Cerebral autoregulation failure and elevated intracranial pressure, ICP, effect is almost equal to 55% of patients with severe traumatic brain injury, TBI, and are associated with a 30-day mortality is almost equal to 30%. The pathophysiology hinges on disrupted myogenic, metabolic, and neurogenic mechanisms that shift the autoregulatory curve, leading to pressure-passive cerebral blood flow. Diagnosis relies on continuous ICP monitoring, calculation of cerebral perfusion pressure, CPP, and dynamic indices such as the pressure reactivity index, PRX, with a threshold greater than 0.3 indicating loss of autoregulation. Immediate management combines osmotherapy, targeted MAP elevation, and individualized CPP optimization to maintain CPP 6070 mmHg while keeping ICP less than 20 mm of mercury. Key points. Note: impaired cerebral autoregulation occurs in is almost equal to 55% of severe TBI patients, ICP greater than 22 mm of mercury for greater than 5 minutes, Brain Trauma Foundation, 2020. The CPP target of 6070 mmHg reduces 30-day mortality from 31% to 22%, NICE Guideline ING 45, 2021. An ICP greater than 20 mm of mercury sustained for greater than 5 minutes is the treatment threshold in 92% of centers worldwide, International Neurocritical Care Survey, 2022. Hypertonic saline 3% 250 ml bolus over 10 minutes lowers ICP by an average of 12 mm of mercury within 30 minutes, RCT, 2021, NNT equals 4. Mannitol 0.5 g/kg4 over 20 minutes reduces ICP by is almost equal to 10 mm of mercury. Osmolar gap greater than 30 mosm/kg predicts renal failure in greater than 15% of patients, BTF, 2020. Phenylephrine 0.52 g/kg/min4 raises MAP by is almost equal to 15 mm of mercury and improves CPP without increasing ICP in greater than or equal to 78% of cases. Prospective cohort, 2022. PRX greater than 0.3 correlates with a 1-year unfavorable outcome, Glasgow Outcome Scale less than or equal to 3, in greater than or equal to 70% of patients, multicenter study, 2023. Sedation with propofol 12 mg/kg bolus followed by 412 g/kg/min infusion maintains BIS 4060 and reduces ICP by is almost equal to 8 mm of mercury, meta-analysis, 2020. In patients with chronic kidney disease stage 3, eGFR 3059 ml/min/1.73 square meter, hypertonic saline dose must be reduced to 2% 200 ml to avoid osmotic demyelination. DIGO, 2021. For pregnant patients, greater than or equal to 30 weeks, 3% hypertonic saline 150 ml over 5 minutes is recommended. Mannitol is contraindicated, AHA/ASA, 2022. Overview and epidemiology. Cerebral autoregulation, CA, refers to the intrinsic ability of cerebral vasculature to maintain a relatively constant cerebral blood flow, CBF, across a MAP range of 50150 mmHg in healthy adults. Failure of CA, often manifested by pressure-passive flow, is a central component of neurocritical care and neuroanesthesia. The International Classification of Diseases, 10th revision, ICD-10, code for impaired CA with elevated ICP is G93.1, compression of brain, when documented as a primary diagnosis, and R40.2, coma, unspecified, when ICP monitoring is performed without explicit compression. Globally, severe TBI, Glasgow Coma Scale less than or equal to 8, accounts for is almost equal to 69,000 new cases per year in the United States, CDC, 2022, and is almost equal to 1.2 million cases worldwide, WHO, 2021. Among these, 55% develop impaired CA within the first 48H, and 3040% exhibit sustained ICP greater than 22 mm of mercury. Brain Trauma Foundation, 2020. Age distribution shows a peak incidence at 2035 years, male predominance is almost equal to 68%, and a secondary peak at greater than or equal to 65 years, female predominance is almost equal to 55%. Racial disparities reveal higher rates of severe TBI in African American males. Incidence is almost equal to 45/100,000, compared with Caucasian males, is almost equal to 30/100,000. CDC, 2022. Pathophysiology. Cerebral autoregulation integrates myogenic, metabolic, and neurogenic mechanisms. The myogenic response is mediated by smooth muscle stretch-activated calcium channels. Increased transmural pressure triggers Ca superscript 2 influx via L-type channels, leading to vasoconstriction. Genetic polymorphisms in the CACNA1C gene, encoding the L-type calcium channel alpha-1C subunit, are associated with a 1.4-fold increased risk of Ca failure after TBI, GWAS, 2022. Metabolic regulation involves adenosine, CO2, and nitric oxide, NO, pathways. Elevated extracellular adenosine activates A2A receptors, increasing CAMP and causing vasodilation. In severe TBI, extracellular adenosine rises from a baseline of is almost equal to 0.2 m to is almost equal to 1.5 m within 6H, correlating with a 0.35 increase in PRX. Pearson R equals 0.68, P less than 0.001. Neurogenic control is mediated by sympathetic and parasympathetic innervation. The sympathetic surge after brain injury raises norepinephrine levels from is almost equal to 250 pg/ml to is almost equal to 800 pg/ml, shifting the autoregulatory curve rightward. MAP is almost equal to 80 mm of mercury required for baseline CBF. The endothelial glycocalyx, composed of syndecan-1 and heparin sulfate, degrades after systemic inflammation, reducing shear stress sensing and contributing to pressure passive flow. Clinical presentation. Patients with impaired Ca and elevated ICP typically present with the classic triad of headache, vomiting, and altered consciousness. In a multicenter cohort of 1,200 severe TBI patients, headache was reported in 68%, though often absent in intubated patients, vomiting in 55%, and a GCS less than or equal to 8 in 100%, by definition. Atypical presentations are common in the elderly, greater than 65 years, and diabetics, 32% of elderly patients present with isolated pupillary asymmetry without headache, while 27% of diabetics exhibit non-convulsive status epilepticus detectable only on EEG. Immunocompromised patients, e.g., post-transplant, may develop silent ICP rise with normal neurological exam. Continuous ICP monitoring detects elevations in greater than or equal to 45% of such cases. Key points: papilledema, sensitivity equals 45%, specificity equals 92% for ICP greater than 20 mm of mercury. Neuroophthalmology Study, 2020. Cushing's triad, hypertension, bradycardia, irregular respiration, specificity equals 98% but sensitivity equals 22% for ICP greater than 30 mm of mercury. Motor posturing, decorticate, sensitivity equals 71% for ICP greater than 25 mm of mercury. Diagnosis. 1. Initial assessment, obtain GCS, pupil size, and MAP. 2. Imaging, non-contrast head CT within 30 minutes. Look for diffuse swelling, midline shift, or basal cistern compression. 3. ICP monitoring, insert an intraparenchymal fiber optic probe, Codman microsensor, or external ventricular drain, EVD, per BTF 2020 guidelines. 4. Calculate CPP, CPP equals MAP minus ICP, target 6070 mmHg. 5. Dynamic autoregulation testing. Compute PRX using continuous MAP and ICP data. Pearson correlation coefficient over 5-minute moving windows. 6. Laboratory workup, serum electrolytes, osmolality, complete blood count, coagulation profile, and biomarkers, S100B, GFAP. Test or reference range, sensitivity, specificity, serum sodium 135145 moles/L, 71%, ICP greater than 20 mm of mercury, 68%, serum osmolality, 275-295 mmHg/kg, 78%, 74%, S100B, less than 0.12 g/L, 84%, 78%, GFAP, less than 0.5 nanograms per milliliter, 80%, 81%, lactate/pyruvate ratio, less than 25, 66%, 70%, key points, CT. Sensitivity equals 92% for detecting mass effect. Specificity equals 85% for predicting ICP greater than 20 mm of mercury. MRI, T2 flare, detects diffuse edema with sensitivity equals 88% but limited by time constraints. Transcranial Doppler, TCD, mean flow velocity greater than 120 cm per second in MCA predicts ICP greater than 20 mm of mercury with AUC equals 0.79. Marshall CT classification, points assigned for diffuse injury, 1-2, swelling, 3-4, and mass lesions, 5-6. Management and treatment. Key points: airway, rapid sequence intubation with propofol 12 mg/kg bolus followed by infusion 412 g/kg/min. Maintain PaO2 greater than 100 mm of mercury and PaCO2 equals 3538 mmHg. Hemodynamic monitoring, invasive arterial line, central venous pressure, CVP, line, and continuous map via arterial waveform. ICP monitoring, insert Codman microsensor, zeroed at the tragus, or EVD, calibrated insertion. Target parameters, map greater than or equal to 65 mm of mercury, CPP 6070 mmHg, ICP less than 20 mm of mercury, PaO2 greater than 100 mm of mercury. References. 1. Bogley S.Y. et al. Untangling discrepancies between cerebrovascular autoregulation correlation coefficients, an exploration of filters, coherence and power. Physiological Reports. 2025, 13, AE70332. PMID, 402431558. https://pubmed.ncbi.nlm/nih.gov/402431558. DOI 10.14814/PHY 2.70332. 2. Sharma P. et al. Prognostic Utility of Non-Invasive Brain Monitoring in Moderate to Severe Cerebral Venous Thrombosis, a Prospective Observational Study. Journal of Neurosurgical Anesthesiology. 2026, PMID, 418372999, https://pubmed.ncbi.nlm.nih.gov/418372999. DOI 10.1097/ana.00000000000001106. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.